All right. So, for the next talk on iGlarLixi, a solid approach to break treatment complexity by our own Dr. Mohan Badgandi. Chairing this session, we have Dr. Deepthi P, consultant physician and diabetologist at Rivan Multispecialty Clinic, Bengaluru. And we would like to call back on stage Dr. Mohsin Aslam, consultant physician and clinical endocrinologist at the Asian Institute of Gastroenterology, Hyderabad. Thank you, sir and ma'am, and please introduce our next speaker.
The next topic, iGlarLixi, a solid approach to break treatment complexity. So it's high time. Let's make that type 2 diabetes treatment in a more simplified way by adding some fixed ratio combination. To talk on this, I welcome Dr. Mohan Badagandi, Senior Consultant Endocrinologist at Manipal Hospital, Bangalore. Over to you, sir.
Thank you
Please
very much.
welcome.
Thank you very much, Disha Group, for inviting me for this CME and this talk. Uh, what I'm going to do is, today's topic is a solid approach to break the complexity of type 2 diabetes management. And today we are not only lucky, we are fortunate to have GLP-1 receptor agonists while we are still alive, to use and provide clinical care with these group of molecules to all our type 2 diabetes patients. So I have no disclosures, no conflict of interest, and this session is sponsored by Sanofi. And when you see that type 2 diabetes patients walk into your clinic, the majority of them who are not controlled or inadequately controlled are usually on either 2 or 3 drugs or 3 OADs. And putting another or adding another molecule OAD is worthless because it does not reduce the HbA1c or does not prevent the long-term complications of diabetes. Therefore, we have to think scientifically what best we can do. So the concept is very clear today. Our main aim is not only to achieve glycemic control, we want to prevent weight gain, and also we have gone one step ahead and we want to provide weight loss, which is much beyond what was seen with the diet and physical activity. And again, we want to prevent the hypoglycemic events and improve the quality of life. So what options we have? We have either adding a basal insulin. Basal insulins, as you know, we have Glargine and we have Degludec, and we have basal plus therapy or basal bolus therapy, which some of our patients may need it. And we also have pre-mixed insulins in the form of 30/70 as well as 50/50. There are a few patients who do respond to these pre-mixed insulins. Otherwise, we have the best solution for type 2 diabetes management today is the addition of GLP-1 receptor agonists, either short-acting, long-acting, along with the basal insulin. Now, as you all know, today's talk is mainly focused on iGlarLixi, that is Glargine, which is a long-acting insulin, flatter insulin, which has been in the market for last 15 to 20 years. And then we have a GLP-1 receptor agonist called lixisenatide, which is also available, and the fixed drug combination is available to us for use in type 2 diabetes management. Now, if you look at various regimes, they have their own advantages and disadvantages. Rapid acting, when you add, the patients tend to gain weight and patients tend to have hypoglycemic events, and patients have to adjust, and the complexity of self-management increases, and patients are on multiple injections. And if you use pre-mixed insulins, you have a limitations of flexibility, and you cannot really achieve a very good glycemic control, and sometimes you also have nocturnal hypoglycemia. That's why GLP-1 receptor agonists are much preferred combinations, and today we are fortunate to have these FDCs which have Glargine plus lixisenatide. Now, what are the advantages and what opportunities could a fixed drug combination of basal and GLP-1 provide to the patient? One is multiple physiological defects can be impacted, and then complementary mechanisms of action, and increased convenience of taking either once a day or twice a day, and improved compliance and improved adherence, and earlier achievement of greater reduction in the glycemic profile, and also risk reduction from the patient side, and potential to delay the underlying disease progression in most of your patients. Now, if you look at GLP-1 and the glargine combination, on one side, when you use a long-acting basal insulin, you tend to target the fasting blood sugar. Once the fasting blood sugar comes down, there is a knock-on effect on the daytime blood sugars. The glargine may not give you a very good reduction in the postprandial glucose, but when you add GLP-1 receptor agonist to that, it can give you a very good reduction in the postprandial blood glycemic profile. So what happens, how this is achieved? Because 7 out of 8 the biochemical or the parameters which are wrong in type 2 diabetes or which are defective can be addressed by using a glargine GLP-1 receptor agonist. That is, one is reduce the hepatic glucose production and reduce gluconeogenesis and increase glucose uptake by muscles, and also prevent lipolysis and increase glucose dependent insulin release and reduce the glucagon secretion. So hepatic glucose output at night is less, the fasting blood sugar comes down, and satiety is reduced. They feel full when they are on GLP-1, and also there is a delayed gastric emptying. So they feel full all the time, and they don't tend to go on defensive snacking. So you have various global guidelines which ultimately tell you the same thing, that instead of considering another OAD or prandial insulin, what you can do is you can go for a FDC combination, which give you much better reduction in the composite parameters, and also prevent weight gain, as well as give you a better hypoglycemic profile. Now, this is based on the SOLI-D study, which compared iGlarGaspart along with side-by-side iGlarLixi, and that showed a significant reduction in the HbA1c, and significant reduction in the weight gain, and significant reduction in the hypoglycemic events as compared to iGlarLixi. In that way, it was not at all inferior to iGlarGaspart, which is also available for quite some time, and most of you must have had a good experience. Now, if you look at HbA1c reduction, there is a significant amount of HbA1c reduction with iGlarLixi. You can use it once a day, but you need to identify which is a major meal of the patient. Is it the dinner, or is it lunch, or is it breakfast? You can use iGlarLixi any once a day, but what happens in our patients, we are more prone to eat either 2 big meals or all 3 big meals, and sometimes our carbohydrate content is more. That is why one iGlarLixi given in the evening may not give you a very good glycemic profile. Sometimes some patients will need it either twice a day, morning and evening, or they can need morning and afternoon as well. So that is the way you will have to tune the iGlarLixi according to your patient's duration of diabetes, as well as the carbohydrate intake and the number of major meals that a patient has. And if you look at these patients' 7-point profile, the glycemic profile starts to improve quite quickly, and you need to see that the excursions start coming down and the patients do very well. And there is the insulin dose required, that is the prandial or the basal insulin required, also starts to come down in these patients. So if you look at the side effect profile, that is the hypoglycemia, and the total number of hypoglycemic events are also much less, and level 1, level 2 or severe hypoglycemic events are very few seen in iGlarLixi as compared to iodec aspart, which is more commonly used now. So there was another study which was conducted in China where 24 weeks double-blind head-to-head study was done in Chinese patients, and that also showed non-inferiority as far as the HbA1c reduction was concerned, and superiority in body weight management, as well as more patients achieved composite parameters and lower risk of hypoglycemic events, and no unexpected safety findings. Now, this iGlarLixi pen is available only in one strength in India, that is 100 units of glargine is combined with 50 micrograms of lixisenatide. So it is really 2:1 ratio. So that is how, when you use about 16 to 20 units of this pen, you get roughly 16 units of glargine and 8 units of lixisenatide. That gives you a much better glycemic profile. So you can adjust up and down 2 units at a time. In most of the patients, you can train them and they will be doing very well. And weekly dose adjustment, self-management is always better than contacting a clinician, or you can train your dietitian or diabetes nurse, and also you can have a diabetes helpline and they can work with you. Now, it can be used in elderly patients, renal impairment. We have not used in pregnancy because we don't have permission to use it, as well as we don't have much experience. We stick to our basal bolus therapy in most of these patients. And hepatic impairment also, we can use it either in the morning or in the afternoon. Try to avoid it in the night because these people are likely to go into nocturnal hypoglycemia. So I think that is my short talk, and thank you very much. And if there are any questions, I'll answer. It is available as once daily injection, and 1 hour prior to meal one has to take it because it needs to be released and act on the postprandial glucose levels. Thank you very much.
Thank you so much, sir.
Yeah.
Sir, officially it is indicated once a day.
Yes, there is nothing like official. Type 2 diabetes management is individualized, highly tailored, and intensive and aggressive. You can use it either in the evening or morning.
Okay, but can we split the dose?
Yes, I am using it twice a day. Because
So
as I told you, most of our patients, this was introduced in the West, where the evening meal is a major meal, or a supper is a major meal. And in our country, major meals are probably either lunch and dinner, or breakfast and lunch, or breakfast and dinner. Depends on how you take the history and how you, design your insulin regimen for your patient.
So, sir, deciding on the insulin part, when we have to put the patients on these kind of insulin, do we need to wait for the basal failure, or we can start from the beginning?
No, so far I have not heard any basal failure. Basal failure is, not really seen, because what you need to do is, if somebody has got, say, postprandial higher, say post dinner, and also the fasting is higher, iGlarLixi works very well before dinner. If somebody has got, say, post breakfast higher and evening pre-dinner blood sugars are very high, given in the morning it works very well. If somebody is having 2 meals a day, breakfast and lunch, or breakfast and dinner, then you can give it either prior to breakfast, a bigger dose, and a smaller dose, or say 50% dose prior to dinner, and they do well.
Thank you so much, sir, for your insights. Any other questions? Thank you so much, sir.
Thank you very much.
Thank you, Mohan sir. Thank you, chairs. I request the speaker and the chairs to head over to the adjacent area to receive the mementos. Thank you very much.